This shows you the updated event-free survival, which was significantly positive, as you can see here, with a difference in both the overall population that's clinically important, as well as in patients who had a no PCR. So this is particularly important and really changed our thinking. Patients who did not have a PCR, who have a worse outcome, had a better outcome if they received pembrolizumab.
The International Society of Oncology Prevention and Treatment, or ISOPT, believes every adult deserves to know their cancer risk before cancer arrives.
So my topic today was to give updates from ASCO 2026 on triple-negative breast cancer. And we had actually a number of presentations, mostly were updates on prior studies. So a detailed analysis. And we really just saw one new study, and I'll show you that. These are my disclosures. So the topics we're going to discuss are neoadjuvant therapy for triple-negative disease. There was a final analysis at almost 8 years of median follow-up for the practice-changing neoadjuvant and adjuvant Keynote 522 trial, looking at pembrolizumab added to standard chemotherapy. There was an interesting small investigator-initiated study looking at radiation plus pembrolizumab as an induction to try and induce an immune response, which I think is a big interest for all of us, particularly in breast cancer, to amplify the host immune response, turning cold tumors hot. And then the new trial was Helen Trio 011 in the neoadjuvant setting, looking at adding immunotherapy to a non-anthracycline chemotherapy backbone. There was a small component to patients from I-SPY 2.2 that looked at a combination immunotherapy approach without chemotherapy. I'll show you that with T-DXd plus an anti-PD-1 TIGIT bispecific antibody. And then for metastatic disease, we saw updates from ASCENT-04, ASCENT-03, Entropia and Breast-02, all secondary endpoints, as well as some biomarker analyses. And then another new trial, so one in each setting, PanCu Breast-02, looking at the bispecific isobrand in pretreated triple-negative breast cancer. So let's start with Keynote 522 first. This was a neoadjuvant trial that looked at the addition of pembrolizumab to a backbone of carboplatin paclitaxel, followed by anthracycline cyclophosphamide, and then pembrolizumab was continued post-surgery in a blinded fashion, placebo-controlled. The median follow-up now is 7.8 years, and we already know from multiple different analyses at different time points that there was an increase in PCR rate, and that was defined in half of the 1,200 patients enrolled in this trial. There was increased event-free survival, shown at a median follow-up of 39 months, and increased overall survival, shown at a median follow-up of 75 months. We now have almost 20 months additional follow-up. In the underlying population, many patients had at least some expression of PD-L1, but interestingly, in the analysis of this data, this did not impact the benefit of pembrolizumab. What we saw was that patients who had PD-L1 positive disease have more chemotherapy responsive disease, and you'll see that in the Helen trial as well. PD-L1 positivity does not predict benefit from pembrolizumab, which occurs across PD-L1 staining, but it does predict benefit from chemotherapy. Weekly carbo versus every 3 week was given in 57%. Most patients had T1, T2 lesions, and about half had node-positive disease. This shows you the updated event-free survival, which was significantly positive, as you can see here, with a difference in both the overall population that's clinically important, as well as in patients who had a no PCR. So this is particularly important and really changed our thinking. Patients who did not have a PCR, who have a worse outcome, had a better outcome if they received pembrolizumab. Additional data that was presented and published by Lajos Pustai from Yale showed that what happens when you add pembrolizumab is you shift the residual cancer burden down. So you have more patients with RCP1 and 2 than RCP3, and this improves event-free survival. In addition, what we saw here, which was quite interesting, was this suggestion of a small benefit in patients who achieve PCR who receive pembrolizumab. This is not statistically significant and is not a statistically valid endpoint, but the difference is almost 5%, which is quite intriguing and suggests that all PCRs may not be the same. Overall survival was similarly improved with ongoing follow-up, with a very significant difference in overall survival based on patients receiving pembro versus not. And you can see again, there's a small window in the PCR patients with improved survival, kind of a hypothesis generating interesting finding. And then patients who did not achieve a PCR had a significant improvement in their what appeared to be a clinically significant improvement in overall survival if they received pembro. It's important to keep in mind that this was not a powered endpoint. And as you can see, the confidence intervals do cross 1 here, but the hazard ratio is 0.76, and the difference here is 9.2%. So it's quite intriguing. So this is the distant recurrence-free survival, as you can see, and that mirrors the data I've already shown you. And so in summary, what we're seeing, unfortunately, the transfer over seems to have hidden a lot of my English words, but the long-term outcome is superior with pembrolizumab at almost 8 years of median follow-up. There was a shift to lower RCB, and this overall survival and PFS difference in patients who achieved a PCR is interesting, but I don't think we'll ever be powered in trials to see this be statistically significant. There were no new immune toxicities with longer follow-up, and there were additional discontinuations in the pembrolizumab group. You can't see these numbers except for in the Chinese version over here, but you can see that there was really a big difference, almost a doubling in the early discontinuations. But despite that fact, and probably due to the fact that patients do better who have some immune-related adverse events, we still saw this significant improvement in disease-free and overall survival, as well as distant recurrence-free survival. So next, we're going to talk about this TRAD trial, which is quite intriguing. Hopefully all of this is visible, not quite all of it. But this is a phase 2 trial that looked at an induction with pembrolizumab and radiation to see whether or not you could turn cold tumors hot, stimulate an immune response. So what you can see here is that patients received 1 dose of pembrolizumab, either with no radiation, a low dose of radiation, or high dose. And they got 3 doses. Then they went on, they had a biopsy, and then they went on and received standard Keynote 522 treatment. These are patients with 55 patients with early stage high risk triple negative breast cancer. Their primary endpoint was the T cell infiltration. And again, I can't really see this behind me or on the screen in front of me. But what you can see is that there was indeed more T cell infiltration in patients who received the induction radiation therapy and pembrolizumab, which was quite intriguing to see that you could actually induce this T cell infiltration. And T cell infiltration actually predicted a higher rate of pathologic complete response. In addition, although PCR rates were slightly higher in the radiation therapy arms, they really saw was that if you used a combined integrated tumor and nodal early response biomarker, these patients had a markedly higher PCR rate. They saw that at 2 weeks, the nodal response was higher in patients who received radiation, even when they looked at the nodes that were not radiated. And this combination predicted higher PCR rates. So quite intriguing. And this encouraging increase in PCR and increased T cell infiltration and tumor regression at 2 weeks suggests that we may be able to impact the immune response in a way by using an induction approach. There already was a suggestion in the German trial that where if you gave an induction of immunotherapy, you might increase the PCR rates. But this didn't pan out to a difference in event-free survival. But further larger trials exploring the ability of radiation to prime the immune response, I think, would be important. So this is the Helen trial that looked at pembrolizumab, an anti-PD-1 antibody, in combination with docetaxel and carboplatin as neoadjuvant therapy for triple-negative breast cancer. The control arm received docetaxel and carboplatin, and this was not placebo-controlled. The randomization was 2-to-1, and you can see the eligibility as outlined on this trial. As you can see in the baseline characteristics, a little more, about 2/3 of the patients had positive nodes, and most patients had stage 2 disease. And this trial was conducted in China, so all patients were Asian. PD-L1 expression is shown here, and this is really looking at combined positive scores with a cutoff of 1 or not. And you can see that the majority of patients had at least some PD-L1 positivity. What they showed as a primary endpoint, this trial was powered for PCR and not event-free survival. Was not surprisingly, PCR was significantly improved in patients who received pembrolizumab, as we would expect based on data from the pembrolizumab Keynote trial. Interestingly, if you looked at the patients who had intent to treat versus PD-L1 positive or not, what you see is exactly what we saw in the Keynote 522 trial. PD-L1, even a little bit of PD-L1 predicts a better response, a better PCR rate. But the delta, the improvement adding an immunotherapy is the same, whether or not you have PD-L1 positive or negative disease. And this is very important when you're thinking about regulatory approvals. So what you can see here is there's almost a 10% difference in the patients who are PD-L1 negative, even though these numbers are quite small, and in the intent to treat population. Obviously, the PCR rates are higher in patients who have PD-L1 positive disease, but we know that this predicts chemotherapy sensitivity. So there were the usual immune toxicities, nothing different than what we would expect, and patients tolerated therapy well. Event-free survival is shown here. It's early, and the difference is about 3%. But again, this wasn't powered for event-free survival. Here's this disease-free and distant disease-free survival, again, not really powered for looking at these endpoints as yet. So what we saw was a significant improvement in PCR with the addition of pembrolizumab to a non-anthracycline regimen. And I think patients in general, although docetaxel and carboplatin can be tough for 6 cycles, we would like to avoid anthracyclines. There's a small but real risk of secondary malignancies and also a risk of cardiac toxicity over time in our older population. I don't quite understand why pembrolizumab was given on day 3 of the regimen. And I think it is important to keep in mind that the benefit is regardless of whether or not patients have PD-L1 positive disease or not. But I think that the era of doing trials where we have a control arm without immunotherapy for triple-negative breast cancer that's at least 2 centimeters or greater or node positive is closed. We shouldn't be doing these trials anymore. We should be looking at which patients are doing better, need a shorter course of therapy, maybe don't need pembrolizumab in the post-neoadjuvant setting. And there is an ongoing trial looking at stopping pembrolizumab at surgery in patients who achieve a PCR out of the Alliance Cooperative Group in the United States. So this is our I-SPY 2.2 small neoadjuvant trial. This is an adaptively randomized neoadjuvant trial with multiple different targeted agent blocks in Block A, and they can be used as rescue or in Block B. In this setting, we gave rilvegostomig, referred to as Rilva, an anti-PD-1 and TIGIT bispecific antibody in combination with the antibody-drug conjugate trastuzumab deruxtecan for just 4 doses. Patients are then evaluated by MRI and biopsy. If they have a pre-RCB suggestive of PCR, so the MRI functional tumor volume is greater than 96% decrease, and patients have no cancer on biopsy, they can go to surgery after just at the end of each block. So that's important because what we're doing is individualizing treatment for patients based on their tumor biology as well as their response. We have a gene expression test that allows us to differentiate between immune positive and immune negative tumors, and patients are eligible with MammaPrint high-risk disease, whether or not it's HR positive or HR negative and HER2 negative. So what we saw, and actually just to show here, the HR positive, hormone receptor negative, the HR positive and HR negative group combined, the immune positive patients were 45% of the total population. This shows you the data from patients who went on to Block A versus Block B or C, and it tells you how many patients went to surgery. So across all of the blocks, 72% of patients achieved a PCR. Among the patients who achieved a PCR, 62% of those did that with just 4 doses of Rilva and T-DXd, avoiding chemotherapy altogether. The majority of patients, 97%, achieved a PCR without receiving anthracyclines at all. So this gives you an idea that you might be able to personalize therapy based on a real-time evaluation of response using a immunotherapy induction. We also were very careful about safety and monitored these patients carefully. So what we did was to evaluate interstitial lung disease with CT scans and on a serial basis every 6 weeks during the 12 weeks of treatment. We also evaluated pulmonary function tests and the oxygenation with a 6-minute walk test. That didn't provide any additional benefit, so we would not recommend those. Most of the ILD was grade 1. We had no patients who had death from ILD, and we had one patient who had grade 3 ILD. She was admitted to the hospital and was better in 12 hours. So most patients did very well and completed all therapy, and interstitial lung disease was not affected by sequential treatment. So what about moving to the metastatic disease setting? What did we see at ASCO this year? So we've been very interested in trying to enhance the immune response in metastatic disease, where we know that PD-L1 and TILs are downregulated with burden of disease and with additional treatment. So this shows you the hypotheses between combining ADCs and IO with upregulation of the STING pathways and to increase the efficacy in solid tumors, upregulate immune function. So there have been phase 2 studies looking at combining antibody-drug conjugates plus checkpoint inhibitors with both T-DXd and durvalumab and sacituzumab govitecan and atezolizumab, so all TROP2 ADCs. High overall response rates and very durable responses. And then we saw an update from the Begonia trial. Again, this color all changed with sending the information over. But the Begonia trial looked at two populations, PD-L1 undetermined and PD-L1 high, and showed very nice response rates and durable responses in both groups. So ASCENT-04 explored this with a median follow-up of just over 1 year. So it shows you the prognosis of these patients, that you could see a significant benefit with such a short median follow-up. 443 patients with centrally confirmed PD-L1 positive disease, defined as a CPS of at least 10, who were at least 6 months from their last treatment in the curative setting, were randomized to receive chemotherapy and pembrolizumab based on the data from Keynote 355, or sacituzumab govitecan and pembrolizumab. All treatment was continued until blinded independent central review verified disease progression, but patients who had BICR-determined progression could cross over from the control group to receive sacituzumab govitecan, and 82% of patients did cross over. One of the issues with this trial and all of the trials in the first-line setting is that very few patients received a Keynote 522-like treatment. Less than 5% received prior immunotherapy. About half of the patients in the control arm received taxanes and half gemcitabine and carboplatin. Additional endpoints were presented at ASCO this year, and unfortunately, it's very hard to see it here, but you can see that they looked at time to first subsequent treatment and time to second subsequent treatment, and you can see how these are defined. And then progression-free survival 2, or PFS2, is from time to first treatment until end of the first subsequent therapy. Now, we had an interesting presentation by a statistician, Meredith Regan, who said that PFS2 is a very difficult endpoint, and indeed it is. But my perspective on this is it represents the real world. This is what we do in real practice. You can see that there is a group of patients who do not go on to second-line or later therapy. This number of patients is undetermined because there were still patients on treatment. 43% of patients were still on SG, 23% of patients on standard treatment when this was reported. You can see that about 55 and 55 and 70% of patients went on to second-line treatment. So this data is still relatively immature. Progression-free survival in the initial data analysis was longer by BICR in patients who received SG versus standard chemotherapy with pembrolizumab. And although you can't see this data, you can see the little box that shows that I can't see it actually, but you can see that there were many less F2 events in the SG arm versus the chemo arm, even though 82% of patients who went on to next treatment received SG. And then this shows you the subsequent therapies in the second line setting versus in the third line setting. And I think what's really important, I've highlighted here, which is that most of the patients received SG from the control arm in the second line setting, and yet PFS2 was still longer. As I noted, this is still immature data, but at least it's a glimmer, and we just have no data on this, that the sequencing of treatment may make a difference. Then in triple negative disease, it may be important to put your best foot forward to give these treatments that are more effective in the first line setting versus the second or later line setting. There was a biomarker analysis that essentially showed that the SG arm was improved in terms of outcome with progression-free survival by TROP2 H-score quartiles, by the tumor BRCA subgroups, and by HER2 subgroups, as expected. The number of patients who had tumor BRCA mutations was very small, so it's a little bit difficult to analyze this subgroup of patients. But otherwise, essentially, there was an improvement in progression-free survival across all of these biomarker subgroups. So SG plus Pembro, I think, is a potential new standard of care for patients with untreated PD-L1 positive metastatic TNBC, and the benefit was seen across the biomarker subgroups. It is true that we don't know what will happen in patients who develop metastatic disease who've received neoadjuvant and adjuvant Pembro, but the PFS2 data suggests that order may be important, so we do want to start with a TROP2 ADC. And we know that crossover can be complicated for our pharmaceutical colleagues and our partners, but this is critical as we move forward to really try and standardize access to subsequent therapies that are known to improve overall survival. ASCENTO 3 looked at SG in the first-line setting for PD-L1 negative and ineligible patients. 99% of patients had PD-L1 negative tumors, same chemotherapy backbone versus SG. And you can see that the patients who had recurred within 6 to 12 months represented 20% of the population. The median follow-up in this patient population is only 13 months, so it's just at 1 year. Again, very important. This shows you the improvement in progression-free survival now published, and also the additional data looking at progression. This is PFS2, even though you can't really see it here, with an improvement in PFS2 that's still 4.2 months. The overall response rates were similar, but the duration of response was significantly longer in patients who received SG versus those who received standard chemotherapy, and this was true across subgroups. Unfortunately, again, you can't really see this data at all in the trials, but you can see the boxes. Here's the PFS2 events shown here, and then what about patients who received any subsequent antibody-drug conjugate? You can see 85% of patients in the chemo arm versus 15% in SG, as you might expect. So what we're seeing is improvement in PFS2, again, even though patients received SG in the control arm when they had progressive disease, suggesting that order may be important. And this shows you the specific ADCs that they received, with the majority of patients receiving SG because it was provided by the company. So 81% received SG as the first or second subsequent therapy. Again, the biomarker analysis presented at ASCO showed that there was benefit from SG compared to standard chemo, regardless of the TROP2, the tissue tumor BRCA, or HER2 subgroups. So it's important to understand the impact of crossover in clinical trials, and that this actually impacts your ability to look at overall survival. Overall survival at 14 months is way too early for the ASCENT trials, but there's only a trend, and it may be that the use of SG in the second-line setting, although improving PFS2, does not improve overall survival because all groups were able to receive SG. So I think this is very important because it does reflect the real world, and it's going to be really important in the future to make sure that our patients on these trials have access to approved therapies in the second or greater line setting. TROPION-Breast02 looked at the second ADC, datopotamab deruxtecan, for patients who had PD-L1 or ineligible metastatic triple-negative breast cancer. So there were some notable differences here. The chemotherapy backbone was different, so patients could receive a taxane, but only carboplatin as a single agent, capecitabine as a single agent, or eribulin as options. In addition, the median follow-up was twice as long at almost 28 months, so very interesting. They had both overall survival and progression-free survival as primary endpoints because there was no crossover provided. 90% of patients were PD-L1 negative, so we know 10% were PD-L1 positive, or they may have an additional response benefit to ADCs. We already know that progression-free survival and overall survival were improved in patients who received T-DXd versus the treatment of physician choice, and this is across subgroups. You can see that 82% of patients received a taxane, but they did include patients who had early relapse. So 15% of patients had recurred in the first 6 months or while on their treatment with curative intent. So the response to taxanes after taxanes is likely to be quite low in that patient population. And indeed, the response rate in the control arm of TB02 was half that in the control arm of ASCENT-03. So you can't look at cross-trial comparisons. I've tried to show you these endpoints again, but unfortunately, again, everything's blacked out for reasons that I don't know. This is the overall survival data. And then they looked at these pre-specified additional endpoints, which I'm not sure that you can see actually here. So it's time to first subsequent treatment is down at the bottom left. Time to second subsequent treatment is on the bottom right. And PFS2 is at the top. And you can see that numerically, all of these are approved with confidence intervals that do not cross 1. And this was a statistically predefined endpoint for TB02. Now, what happened to people with crossover? What treatments did they receive? You can see that any subsequent therapy was in 3/4 of the patients. This was a much longer follow-up, so it's more accurate and mature data about next therapy. 25% of patients did not yet go on to any subsequent therapy, and that matches what we've seen across trials, that patients fall off due to treatment issues or progression of disease and mortality from triple-negative disease. But in terms of receiving an antibody-drug conjugate, what you can see is just 33% of patients received sacituzumab govitecan. One patient received SAC-TMT, another TROP2 ADC, and 15% of patients received T-DXd. So overall, a minority of patients, which may have contributed to the ability to look at an overall survival. So this just shows you a comparison of the trials. There's a difference in schedule and adverse events that's important. Otherwise, it's difficult to do cross-trial comparisons due to the difference in the trial population, as well as the backbone, and the very big difference in median follow-up as well. You can see the difference in ADC's post-progression and the number of patients who had PD-L1 positive disease. It's interesting that the hazard ratios for PFS are quite similar. I think that our choices about using ADCs have to be based on schedule, tolerance from patients, with adverse events being a key determinant of how we decide on treatments, with neutropenia and diarrhea being the most common adverse events for SG, and oral mucositis and ocular toxicities being the most common toxicities for Dato-DXd, as well as nausea. So sequencing also matters. It is a big issue in terms of understanding how we're going to manage the analysis of overall survival as a key endpoint for insurers and our funders for these drugs worldwide. But sequencing is important for our patients. They've taken the trust to participate in clinical trials. We do want to be able to provide them with the best possible treatments in sequence. And I think that this is an important area for clinical, as we design clinical trials moving forward. So there's one other TROP2 ADC that is important to mention, sacituzumab deruxtecan. In a phase 3 trial in the pretreated setting, showed an improvement in progression-free and overall survival similar to the original ASCENT trial. This is a first-line phase 2 trial in 41 patients, showing remarkable overall response regardless of PD-L1 positivity, with a median follow-up of about 1.5 years. There are ongoing combination studies, both with Dato-DXd in the PD-L1 positive population and TroFuse-11, where I'm the co-PI internationally with Aditya Bardia, where we have one arm in PD-L1 negative disease where we're combining SAC-TMT with pembrolizumab, a very interesting approach, and this trial is actively accruing. This is a fascinating trial that was presented at ASCO for the first time, isolantamab brengitecan, called ISOBREN, which is a HER2 EGFR bispecific. And again, there's this problem with transferring slides, but 406 patients with pretreated metastatic TNBC were randomized to ISOBREN, which is given day 1 to 8 every 3 weeks, similar to SG, versus chemotherapy. And this is generally a standard chemotherapy, except for I think we believe that vinorelbine and capecitabine are not effective in patients with triple-negative breast cancer, particularly in the pretreated metastatic setting. But they did show they had dual primary endpoints, and you can see in the little boxes that they showed a marked improvement in progression-free survival by blinded independent central review. And this hazard ratio is one of the best we've ever seen in this setting at 0.29, remarkable. And also the overall survival was significantly improved as well, with a 3.4-month improvement and a hazard ratio of 0.6, also very good. The toxicities of this agent are a little bit different from what we've seen in other agents. So We do see some cytopenias that are significant with isobren, and these are going to need to be managed as we move forward quite carefully, because as we move forward into the first line setting, any combinations will have to take into account the significant cytopenias that are seen with this combination. There is a first line trial with isobren currently accruing internationally. There are a number of sequencing trials to try and understand the benefit of ADCs in sequence, because we do run out of options very quickly in metastatic triple-negative breast cancer. And this is all going to change as we move the TROP2 ADCs into the post-neoadjuvant setting. The post-neoadjuvant trial with datopotamab deruxtecan has completed accrual. SG trial and the SAC-TMT trial are actively accruing. These are in patients with residual disease. So in metastatic triple-negative disease, I think we have a new approach to treatment with PD-L1 positive germline BRCA disease, pembrolizumab and sacituzumab govitecan moving into the first line setting, and chemotherapy moving down. In PD-L1 positive germline BRCA population, we always have to decide if we're giving PARP inhibitor first or not, and that depends on the burden of disease and visceral involvement and crisis. And then in patients with PD-L1 negative disease, I think SG and Dato-DXd are now our first-line chemotherapy choices based on this data. So in summary, significant progress has been made in the treatment of triple-negative disease. There are many future and ongoing directions with individualizing therapy based on appropriate biomarkers. We're looking at tumor-infiltrating lymphocytes, but we know that we need to go farther than that and look at combined biomarkers to best treat our patients. We want to enhance the host immune response with optimal combination therapy. And I would argue that the best way to look at this is in the neoadjuvant setting, and that we need better approaches for immune negative tumors where we see the lowest PCR rates. We do recommend neoadjuvant therapy for all but the smallest tumors under 1 centimeter, and de-escalating and escalating therapy based on response is an important component of future clinical trials. Thanks very much. I think that we do know that the benefit of experience is not in treating everyone, but in treating wisely. And I'll leave you with a quote from Carl Sagan and Albert Einstein: "Somewhere something incredible is waiting to be known. And if we knew what we were doing, it wouldn't be called research, would it?" Thank you very much.